Good evening, everyone. Welcome. I'm Nancy Fitch. I'm the acting faculty for this course, I guess. Thank you to MCAT for filming these presentations. They'll be available for community members to look at in approximately 1 month after the presentation. And we really welcome it if folks would fill out evaluation forms. It keeps the presentations interesting. I have the great honor and pleasure to introduce one of our own here tonight, Dr. Nerissa Koehn. Nerissa was born and raised in Missoula, and after graduating from Hellgate High School, she attended Lewis and Clark, where she majored in natural sciences and had the opportunity to participate in a 5-month study abroad program in Kenya, which helped solidify her interest in cross-cultural and resource-poor settings in healthcare in those settings. She obtained her MD from Harvard Medical School and took an extra year to spend time working with the World Health Organization project in Zanzibar, Tanzania. She did her specialty training in family medicine in Tacoma, Washington, and together with her husband, John Miller, spent the next 8 years working for the Indian Health Service in Zuni, New Mexico, where she was the director of women's health programs. Zuni, New Mexico, and tribal health certainly qualifies as part of global healthcare, I think, global public health. In 2011, she and John moved back to Missoula to help start up the Family Medicine Residency of Western Montana, and she is currently the Associate Program Director for FMRWM and helps oversee the obstetrics and gynecologic parts of the curriculum. The title of her talk is Health Disparities, and I think global public health is in part the story of health disparities. So, welcome, Nerissa.
Thank you. All right, so I'm going to talk a little bit about health disparities, and I'm going to base a lot of my talk today on my own personal experiences working in Zuni, New Mexico from 2003 to 2011. This is a picture actually taken from our backyard in Zuni. Gives you a sense of the landscape there. The area that we're in here is called Black Rock, and you can see some of the black volcanic rock that makes some real interesting formations there. So give a little bit of overview about Zuni, talk about some demographics of American Indians and Alaska Natives, talk about specifically the Indian Health Service, which is what I was working for, and then delve into some of the health disparities that we saw working with the Native American population there. And then what I'd like to spend the majority of tonight's talk sort of focusing on is some ideas or theories about why health disparities exist, and then also some opportunities for how we might mitigate some of the health disparities that we encounter. So let's start with Zuni. Where is Zuni? So this is New Mexico here, and Zuni's about halfway between Flagstaff and Albuquerque, just south of I-40 there. It's only about 10 miles away from the Arizona border. It's a Pueblo tribe, so unlike a lot of the Native American tribes here in Montana that were displaced in order to be placed on reservations, the Zuni have been living continuously in the same area for almost 800 years. They have currently a population of about 10,000 people. The reservation's pretty small. It's only about 400,000 square acres. It's considered to be one of the most traditional tribes. So one of the things that's really remarkable about being in Zuni is that almost all of their members are bilingual, all the way from young children up to older adults. And we worked with a lot of Navajo. The Navajo reservation surrounds Zuni. We had a lot of Navajo who came to our clinic as well. And the contrast with the Navajo is that in the elder generations, you have a lot of people who only speak Navajo. but that's become lost in subsequent generations, more similar to what we see with a lot of other tribes around here, where the younger generations are really losing that language ability. 43%, nearly half, live below the federal poverty line. And the main occupations are government services, which is what we were involved in, and then traditional craft work. And these are some examples here of, they do some really beautiful inlaid jewelry. They're quite famous for their jewelry work. And then those are some carved fetishes that Zuni are also very famous for. Here's some pictures from the Zuni Pueblo. You can see there's still a lot of influence from the Spanish colonial period. So there's a mission church right in the middle of the village. There's some beehive ovens, which are still very commonly used for traditionally baking bread. And this is a picture of Dawa Yalani, which is considered a sacred mountain for the Zuni. In 1680, when Coronado and his men came through, the Zunis actually moved to the top of this mesa and lived there for 12 years. And as you can appreciate, I think, from this picture, it is not easy to get up and down. There are actually only 3 ways that it's even possible, one of which currently requires a very rickety ladder. And it's really neat. If you get up there, you can actually see a lot of pottery shards still scattered around and ruins from when people were living in that area. These are some pictures from the Smithsonian collection that were taken in the 1920s that show pictures of what Zuni used to look like. These are the Oya maidens, named for the pots that they carry on top of their heads. This is a picture of the Zuni Pueblo. Zuni was one of the first sort of high-rise cultures in this country. They actually had up to 9-story buildings at one point in time. And you can also see that part of the way the buildings were designed was for people to enter them through the roof. And that was for safety reasons, so that if they were being attacked, they could pull up the ladders and be more secure. This is a picture of traditional dance ceremonies, and you're not allowed to take any pictures of any traditional ceremonies nowadays. Photography is strictly prohibited, but I can tell you that this is still what it looks like today. So when they have traditional dances down in town, people gather on the rooftops and watch from the rooftops. This is a picture of Shalako, which is one of the most important religious celebrations in Zuni. It takes place at the winter solstice each year in December, and it's a time to give thanks for the harvest. And this is a ceremony that takes place down in the riverbed, where they actually plant prayer sticks for the following year. This is a picture crossing the riverbed. Nowadays, if you crossed it, you wouldn't have to go across any water. Unfortunately, it's been dried up, but this is the traditional riverbed. And this is a picture of the Shalako. So Shalakos are Kachinas, or spirit people, and they're actually 9 feet tall. They're extremely tall. And part of Shalako is they build, each of the Kiva societies builds a new house. It's a year-long activity that they work on. And then the Shalako actually dance all night long, and everybody stays up all night long in those houses. And they actually have to build a trench so that there's enough room for the Shalako to fit in the houses. So they dance in those trenches, and then after Shalako is over, they finish the floor, and it's then used for housing for people. So some of the demographics. There are currently over 5 million people who identify themselves as American Indian or Alaska Native in the United States, almost 2% of the US population. This is a picture just showing where all the reservations are in the United States. As you can see, many of them are located in the western half of the of the country, especially the more sizable ones. In Montana, we have 7 reservations, and we're closer to 5% of the Montana population. As I mentioned, most American Indians and Alaska Natives live in the West. Only 34% actually live on reservations, and this is going to be an important point that I'm going to come back to in a couple of slides. Just out of curiosity, does anybody have any idea what city has the highest percentage of American Indians or Alaska Natives? Any guesses? Somebody's got to have a guess. Gallup? Okay, great. I don't know if Gallup is big enough to qualify as a city, so I bet if they did, it would probably be up there. That's a great guess, too. It's actually Anchorage. Anchorage is the only city that has over 10% percentage-wise. I think it's like 10.1%. Any idea what city has the highest number? This one's actually a little tricky. So it's actually New York City, just by sheer numbers. It's less than 1% of the overall population, but in numbers, it's the highest. It's over 40,000. So the Indian Health Service was established in 1955 to meet federal treaty obligations. And it currently serves about 2 million people. But one thing that's really important about the way the Indian Health Service clinics and hospitals are designed is that they only, for the most part, only serve people who live on reservations. And that means that by far the majority of American Indians and Alaska Natives who live in places like New York City don't have access to those healthcare services. So it's a very uneven representation in terms of access. There's about a $4 billion budget, but that only represents about a little more than half of the needed funding for services, and so shortages in terms of being able to pay for medical services are very common. So let's talk a little bit about some of the health disparities. So the life expectancy for American Indians and Alaska Natives is more than 5 years shorter than that of the overall US population. And this graph shows some of the major contributors to premature death. So the total excess death, if you compare that to the white population in 2005, was 181 per 100,000 people. And the graph shows that a lot of these are due to injury. What's interesting is that a very small percentage is due to infectious disease. That's certainly changed in recent years. Alcohol-induced accounts for a large percentage. And then there's a lot of chronic diseases that also contribute. So alcohol abuse, the rate of alcohol abuse is 6 times that of the overall US population. And hospitalization rates for alcohol-related conditions is 78% higher. Injuries, we talked about on the graph, injuries. So almost 2.5 times higher mortality rates from unintentional injuries, things like motor vehicle accidents, and 2 times the mortality rate from intentional injuries. So homicide and suicide in particular are really difficult issues that a lot of reservations face. Chronic disease, the prevalence of diabetes is over 2 times that of the general US population. Obesity affects more than 1/3 of the population. They have twice the death rate for heart disease and twice the incidence of end-stage renal disease. And Zuni, like I mentioned, population of 10,000, we had our own dialysis unit that ran 3 different shifts. It was going, people would come for dialysis starting at 5 o'clock in the morning. But the inequalities aren't just restricted to health conditions. There are social inequalities as well that I think are really important to mention. So twice as likely to have incomes below the federal poverty level. And this is a major reason why so many American Indians and Alaska Natives don't live on reservations and move to cities for economic opportunities. There's 3 times the national unemployment rate, and they're less than half as likely to graduate from college. So let's move on and talk some now about some of the theories about why there are such health inequities. This is a picture of some of the petroglyphs that you can find if you hike around near Zuni. They're probably hundreds of years old, and there's lots of examples of really beautiful petroglyphs. So first theory is something called the thrifty gene theory. So has anybody heard of the Pima Indians? And what are the Pima Indians famous for? Diabetes, right. So the Pima Indians are located here in Arizona near Phoenix, and over 50% of the adult population has diabetes. What's really interesting is that there is a group of Pima Indians that live in the Sierra Madre Mountains in Mexico that are genetically identical to the Pima Indians living in the United States. And their rates of diabetes are almost negligible. And one of the real differences is that the Pima Indians who live in Mexico still follow a very traditional lifestyle in terms of farming and hunting and gathering, whereas the Pima Indians who live in Arizona have had a dramatic change in their lifestyle since World War II. They've become much more sedentary. They've had to rely on government commodities for food, which includes a lot of processed foods, sugar, white flour, lard. And so their rates of obesity and diabetes have really gone up. And the thrifty gene theory basically theorizes that, people who lived for generations and generations in areas where there were feast and famine cycles developed genes that allowed them to really store fat in times of excess so that when there were famines or times of scarcity, they would have those stores to rely upon, and they became very good at conserving energy when they had the chance. Now in our modern society, there are no famine cycles, and so what was developed as a genetic adaptation now has predisposed them to disease. This picture actually is not of the Pima Indians. This is a picture from Zuni as well, which shows the traditional waffle gardens that they used to plant, but gives you some sense of just how much work was involved on a day-to-day basis just to be able to raise the food, to eat, and to be able to build the structures that they lived in. And the amount of work that went into just sustenance and being able to live on a day-to-day basis was really quite incredible. Okay, so this is another interesting theory called that of historical trauma and epigenetics. This is a picture from the Dutch famine. So at the end of World War II, the Nazis still occupied the Netherlands. And there was a severe restriction on food access, and people ended up living on less than 1,000 calories a day. Over 18,000 people died. And as soon as the war was over, the situation went back to normal and there was food enough to eat. But they did an interesting study where they looked at the children of women who were pregnant at the time that the Dutch famine happened. And what they found is that as adults, those children were much more likely to have a number of chronic diseases, such as diabetes, cardiovascular disease, even breast cancer. And those differences actually persisted into the next generation as well. So the children of those children were more likely to have those chronic diseases. And so there's this theory that something called epigenetics happens that can then get transmitted from generation to generation, where there isn't actually a change in the actual gene sequence, but there's a change in the DNA methylation so that how those genes get expressed is altered, and that can be genetically passed down. So it's a really interesting look at how historical trauma that can be experienced by one generation can get passed down to subsequent generations, even if they had no personal experience with any of that trauma. Who's heard of the Adverse Childhood Experiences study? Okay, good. This is really a fascinating study that's gotten a lot of press in recent years. So this was a study done with Kaiser Permanente. There were about 17,000 people who were enrolled in the Kaiser Permanente health plan. And as part of just routine health screening, they asked people if they would be willing to give an account of any trauma that they had experienced as children. And by and large, what's interesting about the Kaiser group is that, these are people who are relatively well educated, who have health insurance. This is not a particularly socioeconomically deprived group of people. And what they found is that a surprising number of people had experienced some form or another of adverse childhood experiences, anything from having a household member who was incarcerated to experiencing verbal abuse. As a matter of fact, the majority of people experienced at least one adverse childhood event. And as you can see, a number of high percentages of people experience multiple traumas growing up. And then they compared that to the rates of different diseases. So this is a graph showing the risk of adult heart disease as charted against the number of adverse experiences. And what you see is that as the number of adverse experiences increases, the risk of heart disease goes up dramatically, so that if somebody has experienced multiple, 7 or 8 adverse childhood events, they're more than 3 times more likely to experience heart disease as an adult than somebody who had none. And that, I know this slide is a little hard to read, but this applies to a lot of different things. So, for example, alcoholism, drug abuse, depression, suicide attempts, increased risks of anywhere from 5 to 12% increased. That makes sense. I mean, I think that, if somebody's experienced a really traumatic event in their childhood, I think all of us can intuit that they would have higher rates of this as an adult. What I think really challenges us in our thinking is that when you look at rates of obesity, when you look at ischemic heart disease, when you look at cancer, chronic lung disease, liver disease, all of those rates go up as well. And that, I think, is a lot more challenging for us to explain because it doesn't fit our, the pathophysiologic model of how we explain why people have various chronic diseases. Okay, I'm going to talk just a little bit about this theory, which I think is really interesting. This is a professor, I think his name is pronounced Sendil Mullainathan, but I'm not positive. He's a professor of economics at Harvard, and he studies something called behavioral economics, which is a really interesting field of study. Basically, he tries to understand how people's social and physical environments affect their economic actions. And there's a commonly held belief that people are poor because they make poor decisions, make bad decisions, basically. And what he tries to assert is that people make bad decisions because they are poor. And he's done some interesting studies to sort of illustrate that. So we all know that experiencing some level of relative scarcity can be useful. So for example, if you have a limited amount of money, you're going to be a little more careful and creative about how you spend it. Or if you have limited time because of a looming deadline, it forces you to be a little more motivated and concentrate to get your work done. But that kind of single-minded focus comes at an expense. And the expense is that we lose our ability to perform a lot of other tasks well because we are so focused on that one thing. And so a lot of other things get ignored or slighted or put off to a later date, and in particular, long-term planning really suffers. So the other thing that happens in times of scarcity is that people's IQ can actually go down. So this was a study that he did that was very interesting. It was set at a mall in New Jersey. And they randomly asked people who were at the mall to participate in this study. And based on what they reported as their household level of income, they separated them into two groups. So a poor group and a rich group. And they gave them this scenario. They said, imagine you've got car trouble and repairs cost $300. Your auto insurance will cover half the cost. You need to decide whether to go ahead and get the car fixed or take a chance and hope that it lasts for a while longer. How would you make this decision? Financially, would it be easy or hard? And they just told them that scenario, and then they proceeded to administer something called the Raven's Progressive Matrices Test, which is basically just an IQ test. And what they found is when they administered this IQ test, people from, regardless of whether they were from the rich group or from the poor group, they basically performed the same. And then he altered this scenario just slightly. And instead of saying, imagine the repairs cost $300, he said, imagine the repairs cost $3,000. And they did the IQ test again. And what they found was that for the people from the rich group, there was no change in how they performed in terms of their IQ. But for people from the poor group, their IQ performance on this test dropped by 14 points, which is a significant drop. That's actually more of a drop than what you see after people have been sleep deprived in sleep studies for more than 24 hours. And so what it shows is that by simply creating the thought of monetary scarcity, cognitive performance can be eroded even more than being seriously sleep deprived. So what does that mean in terms of health behaviors? So I think we see a lot of the same effects of stress and distraction on attention and self-control in the healthcare realm as we see when people are trying to make financial decisions. So all of us who are physicians have had to struggle with patients who make what we call sort of quote-unquote bad decisions, right? So, patients who are morbidly obese or who smoke or who drink alcohol despite having significant medical comorbidities. And, we think to ourselves, like, why do they do that? It doesn't make sense. It's obviously not in their best long-term interest to make those choices. Yet I think we can all appreciate how difficult it can be to make good long-term decisions when you're faced with really pressing immediate problems. When you are just trying to figure out, how am I going to pay the rent? Or how am I going to get enough food on the table for meal tonight? Or how do I keep my kids safe when I'm living in an unsafe or an abusive environment? So how many of you are in the Issues in Global Public Health class? Okay, good. So for those of you that are in that class, I'm going to be there in a couple of weeks, and I'm actually going to do an exercise with you looking at this idea of sort of the science of scarcity in a little more depth, because I think it's a really fascinating idea. But let's transition a little bit now, and now that we've talked a little about some of the theories about why health disparities exist, let's talk a little bit about some of the opportunities. This is another picture I love from Zuni. One of the great things about when it snows in Zuni is that the sun usually comes out and it melts before you even have to shovel it. So you get a beautiful sun and snow and then not a lot of work. Okay, so what are some of the opportunities? When we were working in Zuni, I was the director of the Women's Health Program. John, my husband, was the director of the Diabetes Program. And one of the things that I think we were really fortunate to be able to experience was a lot of effort, community-wide effort, to develop health prevention programs that were really targeted to being culturally appropriate to the populations that we were working with. So I love these. These are actually a couple of posters that some women in my office made to try and encourage people to come in for mammogram screening and well women exams. And they actually got a lot of the Zuni elders to pose for those pictures to try and encourage people to come in. There also was a DIPS program that was designed to help prevent diabetes, where they would have all sorts of different events on weekends to try and encourage people to come and go on community walks, take part in swimming activities with a new pool. So a lot of efforts to really create a cultural norm in a culturally sensitive way to encourage people to make lifestyle and behavioral changes. Another thing that we had an opportunity to be involved in was helping set up centering pregnancy. So centering pregnancy is a model for doing prenatal care in a group setting. So traditionally people have individual office visits for prenatal care. And what we did there instead was bring together groups of women who were all due around the same time and have them do their visits in that group setting. And the model is really meant to empower women to take charge of their own health care. So they are taught how to check their own blood pressures, how to check their own weights. They're given a notebook where they can record all of that information, and they keep track of it themselves. And when they've done studies on women who've taken part in centering pregnancy, they've found that the rates of preterm birth and low birth weight babies actually go down. And that's remarkable because there is no other intervention that we have been able to identify in prenatal care that has allowed us to reduce preterm births. So it's a really significant finding. I love this picture because this is my daughter Sophia, who is now almost 10, hard to believe, but this was the very first centering pregnancy group that we did, and she was part of it. I happened to be pregnant at the same time. So the Nurse Family Partnership is another really interesting program. This is a program actually that the health department here in Missoula does. And it's meant to identify pregnant women who are in low income groups and match them with a public health nurse who comes to their home and does home visits. And they do those home visits throughout the pregnancy as well as throughout the first 2 years of that child's life. And what they found is that families who take part in the Nurse Family Partnership program have lower rates of preventable causes of death, not only in the children, but in the mothers who take part in these programs. They've also followed these children up to the age of 12 and found that they have less behavioral problems in school. They have less depression, less substance abuse. The families as a whole have lower utilization rates for Medicaid and welfare and food stamps. So really some very interesting and impressive results that have come out of a very focused and targeted intervention on that prenatal and immediate postpartum period. Okay, this is another really interesting study. It's the power of talking to your baby. So this is a study where they actually followed 42 families from different socioeconomic backgrounds, and they were trying to analyze sort of how they talked to their babies and then reanalyze those children once they got to the age of 9. And during that period of time, they basically transcribed and analyzed hours and hours and hours and hours of recorded videotaped interactions between parents and their children. It took them 6 years to get all this data together. And what they found is that all families, regardless of income, do certain basic sort of directive communication with babies. So, things like, don't do that, or, put your toys away, that kind of stuff. But then they noticed that there were some significant differences among the different socioeconomic groups. So children whose families were on welfare, on average, were exposed to about 600 words per hour from their parents. And working class children, in contrast, heard about 1,200 words per hour. Children from professional families heard 2,100 words per hour. And when you add that up by the age of 3, you find that a child from a professional family can end up hearing 30 million more words in those first 3 years of life than somebody who comes from a more socioeconomically disadvantaged family. And when they looked at them at the age of 9, they found that a direct correlation between the number of words that the kids were exposed to early on and their IQ and their performance in school. So really fascinating look at that early childhood language development and the effects that it can have on subsequent school performance. Okay, one last study, which is a study that was done in the Romanian orphanages. So back in the 1960s, Nicholas Ceausescu had taken power and, excuse me, I'm gonna take a quick drink of water. Had done a lot of efforts to try and transform the country from sort of an agricultural to an industrial country. And during this time, thousands of families moved from villages to cities. There were strict measures put on abortions and contraception, and a lot of children ended up in orphanages during this time. And after he was deposed in 1989, these orphanages were exposed to the public. And what they found is it's really quite horrific. A lot of these kids were basically confined to cribs for their entire infant lives. And they would have one caregiver for every 15 to 20 children, where basically all they could do was occasionally, give them a bath and feed them, but that was the extent of the interaction they had from adults. And they found that the children who were in these orphanages had really aberrant social behaviors. They had no ability to interact in a normal social way. They had a lot of strange behaviors like banging their head against the walls and repetitive motions, a lot of self-stimulating behaviors to try and it's almost like all of their ability to interpret emotional cues was just gone. And they also looked at EEG tracings of the brains of these kids, and they were remarkably slowed compared to peer groups who had not been raised in orphanages. So some US investigators actually did a study where some of the children were moved out of the orphanages at the age of 2 and placed into foster homes. And they looked back after the kids were, I think, about 8 years old, at comparing children, all of whom had similar experiences for the first 2 years of their lives and were experiencing very similar aberrant behaviors, demonstrating similar aberrant behaviors at 2 years of age. And they found that those who had been placed in a normal, socially interactive and stimulating environment of a foster home compared to those who remained in the orphanages were able to develop a lot of very normal social skills. Their EEGs normalized, and in comparison to kids who remained in the orphanages that continued to persist in all of those behaviors and EEG findings well into their childhood. So, it's obvious that there are clear health disparities, and that they disproportionately seem to affect people from certain socioeconomic or cultural and ethnic groups. But what I've really tried to focus on is that up until now in our society, I think we've put the blame for a lot of those conditions on the individual. If you're an alcoholic, if you're obese, if you smoke, if you have diabetes, it's because you don't have the discipline or the self-control to make the right decisions. And what I've tried to show with the thrifty gene theory, with the Dutch famine trials, with the adverse childhood experiences, the science of scarcity, is that there's a lot to show that what people are exposed to in their early childhood, or in the womb, or even before they were born, prior generations, what they experienced, things that they really have no control over, can predispose people to certain health behaviors and conditions. And I think there may be a lot less individual control over those things than what we realize. Conversely, there are a lot of things, such as IQ levels and sociability, that we just assume are sort of genetically programmed. And actually, I think there is a lot that we can do to improve it. And programs like Centering Pregnancy, like the Nurse Family Partnership, like Talking to Your Baby, the things that have been shown from there, show that there's a lot of things that we can do on a societal level to improve things like poverty levels, like school performance, chronic disease prevention. But I would really argue that I think the critical time for making those interventions is in the prenatal and infant stages. And what I fear is that I think a lot of the interventions that we have chosen to adapt on a societal level are often focused later on in school-age based children or in adulthood. And I think a lot of the times the cat is already out of the bag at that point. It's very difficult to undo a lot of these things once they've developed. But if we can focus on even very small interventions, like just talking more to your baby at early critical times, I think we can make a huge difference. So I think there's a lot of hope. And I want to end by just mentioning that there are a lot of opportunities to serve in places of high need in this country. The Indian Health Service has scholarships available for physicians. There are also National Health Service Corps scholarships, loan repayment opportunities, and these are open not only to physicians, but a lot of other healthcare professions as well, so pharmacists, physical therapists. The U.S. Public Health Service is an interesting option that I don't think too many people are aware of. John actually did it during the time that we were in Zuni. The U.S. Public Health Service is actually a branch of the military, and so it's a career that has all of the benefits as working for any other branch of the military, but it's a way to serve within the U.S. Public Health Service. And Indian Health Service hospitals qualify as placement sites for that as well. So I'll end with that. Alakwa, thank you. We have time for questions if anyone has any questions.
Thank you.
Yeah. So with the talking to your baby portion of that, was there found to be like an increase and then a decrease? Because I mean, our common conception is that professional parents leave their kids at daycare, or they have a nanny that is only one person instead of two, and I'm just curious if there's.
Yeah, that's interesting. I don't know. I think most of the time that they spent filming was time in the household, so when the parents were there with the kids interacting with them. So that's where most of their recordings took place. One thing that was really interesting from this study is that they did not find any correlation with TV watching. So, there's a lot of like programs designed to help babies learn language, and they actually found there was an inverse relationship. So the more TV exposure, the less language development they had. Any other questions? Yeah?
So when you're talking about the programs in SUNY, the culturally appropriate ones, I was wondering who you worked with and like who was involved in the planning and implementation of those programs?
Yeah, so that's a great question in terms of who is involved in planning and implementation of the programs that we were involved in SUNY. There were a lot of different people, and John can speak to this as well. Within the departments that we were in, women's health and diabetes, there were a number of staff members who were SUNY. So they usually were the ones who helped design a lot of the community outreach programs and health prevention programs that we took on. But there also were a number of programs, grant-sponsored programs through the tribe that went on as well. Is there anything else you want to add, John?
I guess the thing that comes to mind for me on that is that some of the funds from the Indian Health Service are actually taken by the tribes to, like in health promotion activities, and so they design, organize those, and it's not by us doctors at the hospital. I play more of a supportive role in medical advising to those things, kind of a cheerleader from the side. But the tribe itself took responsibility for designing and running these, a lot of these programs.
Yeah, and I think that degree of local control is really key to their success because, without an understanding of what the specific needs are and what's likely to work, it's very challenging to design a program that will have an impact. Yep, in the back.
I'm curious just about that Kaiser Permanente study.
Yeah.
And I was wondering did they make any correlation between which traumas people had when they were younger and what diseases they were predisposed to later? I mean, rather than the obvious of having an alcoholic in the home and becoming an alcoholic.
Yeah.
I mean, I was just curious if there were any other maybe less obvious correlations. And then follow-up question to that is what strategies do they offer to those people overcoming, if you have that childhood trauma, is it just psychotherapy to overcome that, to overcome your diabetes? I mean, you know what I'm saying?
Yeah.
I'm just sort of curious of what strategies made those patients successful in overcoming whatever diseases they had.
Yeah. So I think those are great questions, Charlotte. I think in terms of our specific exposures correlated with specific, more likely to be associated with health outcomes or disparities. I think, what the adverse childhood experiences study was looking at was mainly the number of exposures and the effect that had. I don't know if there's subsequently been sort of subgroup analysis to look at those specific issues. I mean, certainly the example you raised where children raised in alcohol, I think it can go one of two ways. I think children raised in alcoholic families either can be more likely or a lot less likely to become alcoholics, but there certainly is some correlation there specific to that exposure. So it's an interesting question. I don't know offhand of any specific that level of detail of subgroup analysis that's taken place. And then the other question, remind me.
Well, I'm just curious about what strategies.
Oh, the strategies for overcoming, yeah. Sorry. I think that's really the next challenge that we're faced with. I think it's really been a very revolutionary study. It's relatively recent. It's only within I think probably the last 5 to 7 years that it's even come out. And so I think it's really challenged us to rethink sort of our model of how disease develops, and now to be thinking about what we can do to prevent it. And I think one of the things that's very interesting that I know is currently being studied is to look not only at what are the adverse childhood events that predispose to poor health outcomes, but also to look at what are the protective exposures. So we know that there are many people who are exposed to really traumatic experiences as kids who manage to overcome those and not lead to a lot of negative outcomes. And what we're really trying to understand is, what is it unique to that population? What were maybe some of the protective factors that they might have also been exposed to that help them weather that? And so I think that's a really fascinating area that's being studied right now. There was another question. Yeah?
I wondered if among the Zuni you found it necessary to integrate the traditional, historical, cultural elements of their health practices with the message you were trying to sell in order to gain better acceptance, as with their shaman and so forth.
Yeah. So the question is just, how much did we feel the need to integrate their traditional practices? And I think it was very clear that people, in addition to seeking our services, would also seek the services of traditional healers within the community. And there were certainly efforts to, for example, during the time that we were there, the hospital was remodeled, and we actually created a traditional healing room that could be used within the hospital setting for traditional healing ceremonies. So there was only one medical provider on staff who was Zuni. He was a physician assistant. He retired during the time that we were there. But he played a very interesting role because he really bridged both sides of that. And I think it could be very challenging for him at times to have to play that role. But I think he really played a very important role, and we were lucky to be able to work with him during the time that we were there. Yeah.
How common is breastfeeding?
Very common. Yeah. No, they've done a lot of efforts to really promote that, but it is extremely, that was one of the things that Zunis culturally do a lot, so it was great. Yeah. Yeah.
Let's just say, for the sake of argument, that I'm a skeptical political scientist. And how would you reply to someone who's a skeptical political scientist who says that compared to talking to your baby, what really matters is something like Bernie care? It's like doing something really substantial to improve the health of disadvantaged, especially disadvantaged mothers in this country. That's what doctors should be working on. They should be advocating for fundamental reforms in our healthcare system rather than talking to your baby.
I think there is no arguments from me anyway that, more is better. And I think that there are a lot of things that we could do to improve the conditions and exposures that that kids experience. I think the reality is that there are very limited funding streams, and a lot of there needs to be evidence for interventions. And so I think one thing that's really valuable about now having data from a lot of these interventions that have worked is that we're able to capitalize on those things. And I think that, the value of having simple interventions is that they're more easily applicable to vast portions of the population. And I think that certainly if we have evidence to show that simple interventions can make a difference, we should promote those. That's not to say that there's not a lot more that we can do, because I think there's an incredible amount that we can do. And I think that more and more we're realizing that this period, this prenatal period, and the immediate postpartum period is such a critical time. And to be able to really focus more of our attention and energy on that, I think, is really important. So that's what I would say. Yep.
For the cynical political scientists, I don't see those as alternatives. And you could also talk to your baby about how your strategies for changing healthcare. His medical journalist to his kid on the PBS series. It's like, so talk to him about your political views.
That's great. All right, well, thank you very much.